planning for healthcare events, uh, I can tell you the literature shows that most of the population at risk over age 60, only about 20% of them have a will or an advanced healthcare directive. It's actually quite low. And when I would admit people from the hospital for rehab to nursing homes, it was not, it's gotten a little better. Maybe 25% of people had an advanced healthcare directive. Uh, but I can't tell you how many old advanced healthcare directives I've seen or physician order forms that are really old and no longer current. So as you think about what you have done or not done, really visiting these things on an annual basis, or if you get a change of condition, like I just had my change of condition with my arrhythmias. Uh, the and then one of the principles is that elective decisions are usually more thoughtful than ones made in the emergency room. I can tell you as a physician, when I first started, you were not allowed to say whether somebody wanted CPR or not. That was unthinkable in the 70s. That was ethically unthinkable. And then once we started saying, no, that people have a right to make decisions about the intensity of care, um, forms were developed. But I can tell you, most physicians did not do it until there was an emergency, because now in emergency, you've got a particular emergency with a particular prognosis, and therefore now is the time to make decisions. But when you're really sick in an emergency, you may not be thinking that well. I mean, what the British call befuddlement, we call delirium, is extremely common in illnesses over age 70. So that it's much better to make decisions, at least to talk about it with your spouse or partner or family, so they know you're thinking and what your values are, what's important to you. And so that's what I really encourage you to do. And again, with Parkinson's, unfortunately, balance isn't good and falls are common, and fall injuries are common because persons with Parkinson's do not have the protective reflexes when there's a fall. And the medications can cause impulsiveness. So even though you know something's risky, that goes out the window when you get impulsive. So falls are common. At some point, swallowing can be impaired, and then you go into, at least when sick, aspiration can be a problem. Should there be feeding tubes considerations? And then social isolation, depression, communication problems can develop, and then people can become frail and then more susceptible to multiple things. In fact, with COVID, SARS-CoV-2 illnesses, frailty is a risk factor for not doing well, for having emergencies. So there are advanced healthcare directives where you can document your values, goals of care, and treatment preferences. The form itself actually doesn't necessarily do that. It's more the thinking behind creating the form. So kind of homework for doing this. And there are some tools that can help you do that. And then there is this term called surrogate, which is a fancy term for a trusted decision maker, or an alternative decision maker for if you develop befuddlement, or for some reason you lose decision making, at least for complex medical decisions. And there are literally hundreds of these directives. And by the way, just a reminder, if you have questions, if you do them in the chat box, I'll try and look in there. I can't look in right now, but anyway, it's still helpful at the end. I can do that. And these directives you can find on the internet, and I'll give you a website that has some of the more commonly used ones. Most are free. The cost is low, like the California Medical Association's is $5. And there is a need to validate them with 2 other persons. So I just recently did that for my Medicare wellness exam, and I had a neighbor and his granddaughter validate it because my wife couldn't do it without a public notary. And then this is the website right here that you can click on if you, when you get this, this program is being recorded. But if you download this off the internet, the slides, you can just click on this and it'll have a repository of advanced care planning tools and in various languages, for sure Spanish. And it has a conversation toolkit, which I think prepares you for meeting with an attorney for a trust fund or for meeting with your physician for making decisions, or with your family. And then it has basic forms, which I'll show you on the next slide. It has a section on there about frequently asked questions. It has one about how do you decide who should make decisions for you. I can tell you that I've seen plenty of mistakes where somebody's a decision maker who has an agenda that's not your agenda. I mean, that happens. And then you are not going to get the decisions that you would like. You really need somebody who not only knows your values and how you make decisions and what kind of risks you want to take, but you want to make somebody who can make hard decisions. Sometimes there's a loved one who just cannot make those hard decisions. And I can tell you, my wife and I think differently on subjects. And for instance, I would prefer to be cremated, but she wants a formal burial plot. So in advance, we've hashed that out, and I'll do the formal burial plot, even though I prefer to be cremated. And so there are all those complexities, and be sure to talk with them about with your surrogate decision maker. You need to be able to make the decisions on these forms in order to do that. If there's any questions, you should be seeing creating evidence that you do have decision-making capacity, because I've seen plenty of wills and documents challenged in court by people who didn't think you had decision-making capacity. And then there's the various forms like the PULSE form. So these are advanced care directives. There's available on the Coalition for Compassionate Care website. So like if you're Jehovah's Witnesses, you probably want that advanced care directive. And then if you have a dementia and you want to limit care, that would be one way of doing it. The thinking ahead, when I'm going to kind of highlight that, because I was actually involved in its creation with Susan Keller, a local, who's now a local palliative care advocate, who did that for many years. She's now retired. But she developed this workbook available in multiple languages. And we tested it here locally with the mental health department. And the wording is just user-friendly. So even if you don't have mental health problems and you want to have something that you can look at that's right in front of you, this is I think it's an excellent document. And it has a supporting video. And for myself, when I need to know how to do things like change the toilet seat gasket, I'm going on YouTube looking for something. When I needed to know how to use the Narcan spray for resuscitating people with opioid overdoses and having a process in nursing homes to do that, because that's the law now for 2 years, I went on the internet and got a video, because videos work. So personal request form, so this is part of that, this form right here, the Thinking Ahead workbook. It has where I want to be in my final days, how I want to be cared for, where I want my things to go, gifts I want to give, what I want to have happen with my body, how I want to be remembered. These are all things that I think are important to most of us. And it's nice to have a tool that helps us think this through and to have it available for our decision makers. And then they title the Advanced Care Directive, My End of Life Choices, which I think is a patient-friendly way of doing things. And by the way, in geriatrics, we have 4 M's as our goal for an age-friendly health system. The first M is what matters to you, the patient. The next one is medications, making sure we've got the medications right. There is a tendency to not visit medications often enough and to not make sure that the medicines you're on currently are the right medicines for you, that they don't have side effects which are treated. You've got medications which are treating side effects and ones that you no longer need or that are no longer effective. The other M is about how the mind is working. Is it working normally? Do you have a mental illness like depression or bipolar disorder or an anxiety disorder, panic disorder that's active, that's affecting and then the other one is there cognitive impairment or disability that uh, needs to be properly addressed and managed so that your capacities are augmented and your incapacities are respected. Um, and so the four M's are what matters to you, what medications are you on, how is the mind working, and the fifth one is mobility, because falls is actually a common cause of dying in the United States. And falls can be preventable, but there's a whole list of things that need to be considered. So fall risk is something that should always be visited. So anyway, my end of life choices talks about during my final days, my quality of life means, my life support treatment, decision making is, and you can read through these things, but this is done on the basis of that workbook. So this is, again, it's an option. Now, I can tell you what I've done for myself because I have some internet skills, even though my screen sharing skills are not very good, as you saw today. Um, and so I like uh, oh, actually, this slide right here just talks about uh, having decision aids to help you make decisions. For instance, when somebody says, do you want CPR or not? I think there's this is a whole page of information on CPR, what we know about CPR. And the dirty secret about CPR is that it's setting dependent. So when you're answering this question in the hospital, where you have rapid response teams, they don't let you go to having your heart stop before they do CPR. They transfer you to the ICU. CPR outcomes in the acute hospital setting are vastly better than at home, where you do not have all that support. And even in nursing homes, there is not near the support. So if CPR is being started at the point of shock, where the heart, you still have a rhythm, CPR is going to be much more effective than it is when the heart is stopped, which is what it is in the outpatient setting. So the question about CPR is where it's needed. So I can tell you for myself, I've told my wife outside the hospital, I do not want CPR because the results are dismal. And the chances of serious brain injury, even with resuscitation, the chances of living out the rest of your life in a nursing home on feeding tubes are significant. But in the hospital, go ahead, do CPR. Makes perfect sense to me. The same thing about tube feedings. Tube feedings in advanced dementia have not been shown to prolong life because in advanced dementia, the swallowing is so bad that your normal secretions are going to produce pneumonia at the same rate, whether you have a tube in your stomach or not. So it's not a feeding issue. So again, really good information available at the Coalition for Compassionate Care. That's the link to that. And they have a Making Your Wishes Known workbook that's quite good. And then again, this is where my directives are online. And basically, it's like I can tell you that Thinking Ahead workbook and my directives are very much in sync, but allows a lot of free texting. And so when I had my Medicare wellness exam, I printed this up, had my good friends and neighbors do the two signatures, and then I faxed it into my doctor so they could put it into their electronic medical record. Um, It's easy to upload, to share, and my kids all have it. My wife has it. Um, and then every year, or actually every 6 months, it queries me about updating it. So I update it every 6 months. Um, Now, another website that's good is Prepare for Your Care. And the thing that's good about this is the video stories and the multiple languages. This was prepared by Rebecca Sidori at Geriatricia UCSF. It's really quite good for preparing you to make difficult decisions uh, in the future and also to document now. Uh, I took these slides from the Coalition for Compassionate Care. So PULSE stands for Physician Orders for Life-Sustaining Treatment. This has been available by law in California since 2009. And actually I did part of my graduate work project was on implementing this in Sonoma County with Susan Keller. So that I'm very familiar with this process. These are the difference between an advanced healthcare directive and the PULSE is advanced healthcare directive can, be over 10, 15 pages. It's a lot for a for an emergency responder or emergency room doc or somebody who doesn't know you to plow through and get it right. So the PULSE is a translation of that into actionable orders that are commonly, or actionable domains that are common in most emergencies. This is a voluntary form. So if you ever go to a nursing home and they put this in front of you, you absolutely do not need to complete this. It does have a distinct color, so it's easily located by emergency person or by healthcare personnel in an emergency. It has is digitalized in almost all the local healthcare records. Actually, in the acute hospital systems, it's digitalized, so it will reside there. So I actually brought my PULSE form into my physician's office for my recent Medicare visit, and it's now in the electronic medical record. And all you really need on these forms, if you are in a nursing home where they say this is the form that we use for documenting CPR status, which is federal government requires for all admissions that people have the right to say whether they want CPR or not. If you do not complete this form in the nursing home, you will automatically be assumed to be full code and CPR. So you can still refuse to do the form. You'll just be attempt CPR status. And so that your other alternative is you can complete the form by just saying whether you want CPR or not done in the nursing home if a situation arises where it should be offered. And then your physician or nurse practitioner or PA would need to sign it. And then you would need to sign it if you did not have decisional capacity, or substitute decision maker would need to sign it. It is designed to be used in the last several years of life. And the reason for that is that this is physician orders. And physician orders should really be about something that is a possibility in the next couple of years, because people who are perfectly healthy like myself, if they're not updating it on a frequent basis, I could be request very aggressive medical care when in fact my advanced healthcare directive says if I no longer recognize friends or family because of dementia, and I have dementia in my family history, very strong on my mother's side. If I become develop a dementia where I do not recognize friends or family, I do not want CPR or anything to prolong my life. So if the current physician order is do everything, which my physician order is under full intensity treatment, that would no longer be accurate. So if you do a PULSE, you should be really revisiting it every year or two, because it could change as mine, if I become demented, it needs to be changed. So that's the danger of the PULSE and why it's recommended the last several years of life. Revisit these decisions whenever there's a significant change of condition. So the pulse complements an advanced healthcare directive. Again, when I admitted patients to nursing homes, I would only get an advanced healthcare directive from the acute hospital about 20–25% of the time. The rest of the time, it would be a lot of work to get one. So your advanced healthcare directive, you should have it in a spot that's easily locatable in an emergency. So it goes to the hospital with you, along with your physician order for life-sustaining treatment or other forms if you have other forms that have a similar function. Um, there are forms called that only address CPR, and that's where you can get them. Um, and it lacks legal authority if you no longer have decision-making capacity. So somebody else can't make this decision for you, but your physician and a substitute decision maker can, but it has to be signed by the physician. And then there are forms called PIT forms or PIC forms, and these are what we used in nursing homes prior to the development of the PULSed, preferred intensity or preferred intensive care or treatment forms. And these are forms which basically are simple forms that say, do I want antibiotics if I get real sick? Do I want feeding tubes? Do I want CPR? Do I want dialysis? And this sort of thing. And they're not physician orders, and they do not have to be followed by the healthcare system. They're more advisory. And the advantage of these forms is that they do not have the effect of an order 5 years down the road that's going to haunt you if your healthcare is significantly changed and these forms have not been changed. This is what the PULSed looks like: front page, back page. And I'm presuming that many of you have seen these. I can tell you when my wife went to her physician, she was handed this form and asked to fill it out. And I said, now, were you told anything about how to fill out this form? And you know what she said? No. And that's why we're doing this talk, is unfortunately, most of the time, you're just handed this form and it's very obvious that you know how to complete this form. Unfortunately, that's not the case, but this form doesn't fit into the workflow of office-based physicians, and it doesn't fit into the workflow of hospital-based physicians or nursing home physicians. Now, any physician that signs this, and I'll show you where later on, is testifying that this is their orders and that they went over this form with you. So unfortunately, I will tell you a dirty secret. Physicians sign orders like rats. You put something in front of them and they sign them. I mean, unfortunately, that's the way it is because they're very busy, and computers have actually reduced physician efficiency by about a third. So physicians work very hard even when they're working like rats. Now, I want to just break this form down a little bit so that you kind of can see it, number one, and see that there's a bunch of details on this form. On the left side, there's the Emergency Medical Services Administration who have signed off on this form. This is your paramedics in this county. They're the ones that run disasters like fire, emergency evacuations, and all that stuff. The county Mohawk system, but this has your last name, your first name, your middle names. We want to have the identifiers so that this form, if it's a Joe Smith and another Joe Smith, we got the right Joe Smith. There's patient's date, and then when was it prepared? And medical records, usually that number's not on there, but it's not essential. The first decision is about CPR. And this form was designed for the outpatient setting. It will never be used in the hospital setting as the primary document. The hospital will translate the PULSed form decisions into their decisions, because guess what? In the hospital, they got rapid response teams, so that when you're getting sick and you still have a pulse and you're still breathing, they're going to institute CPR if it's indicated, because it's needed because you're not perfusing well enough or you're not breathing well enough. But outside the hospital, in your home or nursing home or assisted living, wherever you're living or at the time, if there's no pulse and you're not breathing, I can tell you CPR is almost worthless unless it's immediately seen or unless you're choking on food. So for myself, I do not attempt resuscitation in the outpatient setting, the out of hospital setting. Um, so that's how I fill that out. So you need to know that when you fill these forms, that this form is not for the acute hospital, it's for the out of hospital, how CPR generally is applied in the outpatient setting. The section B deals with your standard emergencies. If you're found really sick and it's an emergency because you're maybe not perfusing well or you're not breathing well, what do you want to have happen? Now, I am full intensity treatment, which means I could have CPR. And the doc may question it because I said no CPR in section A, but I could have CPR because in the hospital, it makes perfect sense to me. But I do not want to be on a ventilator for 4 weeks. So if I had COVID and was really sick, I would say a trial maybe for a week and reevaluate. But if it looks like I'm not going to, if I'm going to be on this for 4 weeks and end up 50% mortality, I'm going to die anyway. I'm not that invested in the future. That's just me. You may be different. But when you check that sub box, trial period of full treatment, you can quantify that and say, I'm okay for a week, or which is how I would do it. But as I'm going to introduce my mother to you later on, and my mother for the last several years of her life was selective treatment. She was okay with antibiotics and IV fluids. And I can tell you, she had swollen legs where she would get infections of the legs and would get septic and go into the hospital and get antibiotics and IVs. And within a day or two, she was back home because she actually had very good monitoring of her health where she was living by one of my employers, Fox Home Health. And she would just be in there for a day or two with her UTI and back home. So she was selective treatment, but she did not want to be in the ICU. And that's the difference with selective treatment. And in the nursing home, she would have, if she was in a nursing home, she never actually lived in a nursing home, she would have been only transferred if they couldn't do IV fluids and antibiotics. And then I've been a hospice medical director for VNA Hospice, and many of our patients were comfort focused. But I can tell you, you can be on hospice and be full intensity treatment. Because to be on hospice, the only criteria is if the disease follows its predicted usual course, you're expected to be dead within 6 months. But you can revoke hospice for that matter when you get sick and need. But anyway, comfort-focused treatment is designed, and this is the way my mother was in her last 11 months or 10 months of life, was comfort-focused care where the key issue was comfort. We wanted her to be comfortable. She wanted to be comfortable, and we were not going to prolong her life with medical interventions. And so good match for hospice. This next section is one that isn't actually an emergency. And the reason this was placed on the pulsed form as an order is to force physicians, nurse practitioners, and PAs to have a decision with patients about what matters in terms of nutrition. Most people haven't thought of this, but I can tell you, I've seen a lot of people before this was available who would have a tube put in their stomach, who were so cognitively impaired that they didn't recognize that the tube was there to help with their nutritional needs, and they yanked the tube out. Just like they yanked the IVs out and yanked the endotracheal tubes out of the breathing airways. And so it was kind of one of those battles. Are you going to restrain the hands? Is that a way to live? With your hands restrained so you get tube feedings? Anyway, this is worth a conversation with your physician. I can tell you for myself, I'm a trial period of nutrition, see what happens in an emergency, because if it's valuable and it's tolerated and it's a short-term thing, I'm okay with that. But some people, like for religious purposes, will, or because their beliefs are such that their duty is to live as long as possible. Sometimes they'll say, yeah, I'm okay with long-term artificial nutrition by tube. There are some neurologic conditions where the swelling gets knocked out so well, but the mind is still functional and people may want long-term placement. So again, that's why this is on there. Section D is basically whodunit. And I can tell you that I commonly on nursing home admissions would check patient and legally recognized decision maker. And the reason for that is, how are you going to know what matters to a patient if you don't talk to them and ask them? So even my patients with dementia or my patients who were befuddled because they were so sick, I would talk to them and ask them what matters, because a lot of times people will know what matters even if they're confused or even if they have a dementia. There are core values that we have, and you should be able to express your opinion. And I will tell you my mother's example later on. She had a dementia. We still listen to my mother. So I would check both these boxes in that situation. I would first have the discussion with the patient, and then I would contact their surrogate if they weren't at the bedside, and I'd say, this is what's going on. This is what I think should happen, but I talked to so-and-so, and this is what they said. Makes perfect sense to me. What do you think? And then here, if there were advanced directives I could review them and date it. Most of the time I didn't have them. If there's no advanced directive, then that means we should be talking about the importance of advanced directive. And then it's always nice to have who is the decision maker. Now, the reality is most of us who are boomers are of Northern European descent. And people of Northern European descent tend to be highly individualistic and to have themselves a decision maker, number one, but if they are not decision makers, tend to have one primary decision maker. And that's the way advanced healthcare directives were set up. They were set up with that model, the Northern European model. But the reality is, in the Hispanic culture, it's the men in the family generally, but it could be the women, and it could be multiple people. Drives hospital physicians crazy because you can't go to one person for a decision. And if that's the case, you want to recognize this on your advanced healthcare directive or in forms, that there are actually multiple decision makers. There's actually a consensus. I can tell you in Taiwan and in the Asian cultures, it's consensus driven. And in Japan, it's definitely the men and the family. The uncle would have more decisional authority than the wife. So this gets complicated, but anyway, that should be clarified. And then print the physician's name, because we have lousy handwriting, most of us. And how to get a hold of the physician. I put my cell number there because in emergency, that's how you get a hold of me. And then it needs to be a physician with an active license. And with boomers now, there are plenty of physicians without a license. I actually kept my license in retirement, and it's not cheap. It's $800 for 2 years, $400 a year. It's going to go up. Actually, has gone up since I renewed. But that should be there. And now, as of 2017 or 16, nurse practitioners and PAs can do this. Before that time, they could not. And then who made the decisions? If it was the patient, the relationship would be self. But otherwise, what is the relationship? And then signature date, mailing address, phone number. So this is all, section D is whodunit. I can tell you the number of incomplete forms on this section is huge. In fact, it's the majority of the forms because, again, they're not having these discussions about why they're there. The backside of this form, let's see what happened. Backside, there's the backside of the form. The thing I like about the backside of this form in nursing homes is the preparer's name is supposed to be there. Which nurse prepared the form? And how do I get a hold of them? Because when I sign this form, I signed it because I did the process. I never trusted somebody else to help a patient do this because this is complicated. And the turnover of nurses in nursing homes is about 30% per year. So you have a bunch of newbies uh, in post-acute care, at least. They tend to drift to the acute hospital where they get paid twice as much, so you really can't blame them. But they don't do a good job on this area because they're newbies. They just don't have the experience. Um, and so I commonly would want to educate them. So I go back here and say who done it and try and get a hold of them. Unfortunately, this part of the form is not filled out by newbies commonly. So I go to the director of nurses and that sort of stuff and grouse a bit. But the other thing I like about this is what if you, in an emergency, if you can't get a hold of the substitute decision maker, who's next on the advanced healthcare directive to contact? Uh, anyway, because in emergencies, it can be hard to get a hold of people. And you really do want to get a hold of people so that they're aware there's an emergency, and also so you have input, because these emergencies um, are, uh, now they're specific. When somebody has a pneumonia or say has COVID and they're breathing at 40 a minute and they're on 5 liters of oxygen and decisions haven't been made, now you've got a real problem with very specific issues that you can talk to a substitute decision maker about. So these slides are this is out of order. Who can speak for a patient? Anyway, spouse, a partner, a parent, a guardian, a conservator, closest available relative, close friends. And there is something called the EPA law, which has been around since the early 90s that we use in nursing home. And it's actually a process for how we make decisions for somebody who does not have an identified decision maker. And believe it or not, about 10% of our patients don't, which is why doing all this stuff makes sense. Oh, I'm sorry, I'm going backwards. Um, just wanted to run through an example. My mother lived to be 89, almost 89, and she had a mixed dementia and just a bunch of medical problems that you can read there. And she had actually had small bright red blood in her stools for about 4 years, which we ignored because of her dementia. She did not want aggressive medical care, but finally she had such bad bleeding that we could not ignore it. She required hospitalization, transfusions, and got a diagnosis of colon cancer, sigmoid colon, had the typical what we call apple core lesion wrapping around the colon, but wasn't obstructed. And she had the consultations, and what she told us at this point is I've been telling you that I'm ready to die, but she said, I'm not so sure. And so she wanted to know her options. And so got consultations. It was obvious she couldn't take Coumadin for atrial fibrillation anymore, even though she had had an embolic stroke in the past, but it just wasn't safe. So that was stopped. She, from her perspective, was comfort-focused care. But when we had a hospice presentation, she refused hospice. She lived in an assisted living facility. And by law, in an emergency, they've got to send you to the ER. So she actually was selective care. And so we actually did not, I was a hospice medical director. It was my hospice that made the presentation, but she was really quite firm that she did not want hospice. And when I talked to her later, she said, they're going to try and change my religion, because a lot of hospices were religious based early on, and that stuck in her mind in dementia. And then also one of her roommates was on hemodialysis and hospice. And when she stopped hemodialysis, she died quickly. So my mother's conclusion was hospice kills people, and she wasn't ready to die that quickly. So she didn't go on hospice, but she did have an emergency. So that's what we decided on the pulse form. But she did have an emergency and was hospitalized, and actually had was so hypotensive, underperfused the back of her brain, the occipital region, which is your visual cortex, and had cortical blindness for several days. But then it came back. She agreed to go on hospice, and when my sister picked her up on day 4, she said, "Well, I'm on hospice, and they already gave me 2 poisons." And you can't be on hospice in the acute hospital, so my mother was wrong. But my sister asked what she was given. It was generic forms of medicines, digoxin and Lasix, which she didn't recognize, so she thought they were poisoning her. But actually, the chaplain sang Lutheran hymns uh, and didn't try and convert her, and she actually had very good quality of life and died about a year later suddenly. It was actually a good death, and actually quality of life was really pretty good up until about the last 3 weeks when she really started shutting down, which is expected. Uh, so her pulse form was changed when she went on hospice to comfort focused care, and she died in the assisted living. So the pulse can be changed at any time. It actually can be changed in the ambulance. If you've got decisional capacity, you can say, wait a minute, made a mistake for this emergency, let's do it differently. Uh, and a legally recognized decision maker can change it on the basis of the new condition and on their knowledge of what's important to you. And so where do you place this? Used to be when refrigerators were magnetized, you just hold it on the refrigerator with a magnet. But the bathroom mirror, or wherever you take medicines, because the paramedics are going to look for your medicines. So advanced healthcare directive impulse forms or PIT CPR forms, keep them with your meds. And the EMS is going to take them then with you to the hospital. Presuming that is what should happen in the emergency. And at the hospital, basically, what the hospital is supposed to do is keep it in the chart and then send it with you to the nursing home or back home with you. Unfortunately, in California, I've talked to multiple people, all the hospitals basically scan them into their medical records and throw them away, or send them to medical records. They don't travel with you, but they should. So you may need to make out another advanced healthcare directive. Always keep a copy of your pulse, because otherwise you'll need to make it up again, unfortunately. Wherever you go after you are hospitalized, you should review the pulse with the attending physician and nurse practitioner. Physicians are actually allowed to charge for completing the pulse form or doing advanced healthcare directives with you if they spend more than 15 minutes. I can tell you that I rarely spent more than 15 minutes. Usually it took about 5 minutes to do this.